Great. Let's get started. Good morning, everyone. My name is David Jordan. I'm the President and CEO of the United Methodist Health Ministry Fund. Thank you for joining us for today's webinar on access to maternity care in Kansas. We are excited about the turnout and interest in this report. As many of you know, over the last 10 years, many rural hospitals across the country have closed or stopped offering maternity care services altogether. This includes in Kansas, which is second only to Texas in terms of the number of counties considered rural. Rural hospitals are considered at risk of closure due to financial vulnerabilities, due to declining occupancy rates, fixed costs, market pressures, and really just the change of how care is delivered. We're thankful to work with our hospital association and many hospitals across the state to think about how healthcare is changing and how we can work together to strengthen healthcare in Kansas. And this really includes access to perinatal care and maternal health care, including care during pregnancy and after the birth. We know that this care is critical to the health of newborn babies and their mothers, and closures of hospitals and cessation of maternity services often correlate with babies being born early, more infants being admitted to neonatal ICUs, and more women dying during pregnancy or childbirth. So this topic is really top of mind for all of us. We're excited today to provide insight into the growing maternal health care deserts and really the landscape of maternal health care in the state. We're going to present data from a recent report produced by the KU School of Nursing in collaboration with the Kansas Center for Rural Health, which was supported by the Health Fund. We will start with a presentation from the report's lead author, Karen Weiss, who serves as the Dean of the KU School of Nursing Salina and the Christine A. Hartley Rural Health Nursing Professor. Then we'll hear reactions from rural and maternal health experts, including Ann Dwyer, who's an associate research professor at the Georgetown University McCourt School of Public Policy and the Georgetown Center for Children and Families. We'll also hear from Sapphire Garcia, who's the executive director and founder of the Kansas Birth Justice Society, Dr. Beth Aller, a family medical physician at Rooks County Health Center, and Cindy Samuelson, senior vice president of member and public relations at the Kansas Hospital Association. Just some quick housekeeping items before we get started. Given the number of folks on the call, your lines are muted. However, we hope you can use the chat function to engage throughout the webinar. Please introduce yourself in the chat and please ask questions throughout the presentation in the chat. We will be monitoring the chat throughout the webinar and we'll take questions after the presentation and panel discussion concludes. We will also plan to use the raised hand function to call on folks later in the webinar. However, we encourage you to ask questions in the chat throughout. I'm really excited to have this conversation, and I think it's really top of mind because as we're discussing the existing landscape for maternal healthcare in Kansas, Congress is proposing $700 billion in cuts to Medicaid, and the proposal that passed the House, we estimate, will reduce in $3.77 billion in Medicaid cuts for Kansas. And this is largely through reductions in state-directed payments to providers, which really intensifies existing challenges for hospitals and other providers in rural communities. This is particularly concerning as it relates to this topic for services such as obstetrics, which already have experienced a notable decline in Kansas with 17 unit closures since 2010. So we'll be talking about the maternal health care deserts, the landscape, policies, and really how it impacts community and patients. I think we've got a great panel and a great presentation from Dr. Weiss. So I'll turn things over to Dr. Weiss and encourage you to use the chat. Thank you so much again for joining us.
Thank you, David. I'm going to share the slides. It always takes a minute. There we go. So welcome, everybody. I wanted to start out and let everybody introduce the team briefly. In addition to myself, Alex Alsop was the biostatistician, and he collated the data, cleaned the data, which was a yeoman's task. And then I don't have a lot of time to introduce everybody individually, but the rest of the team was public affairs, the public the graphic design artist, and then you, Dana and Danielle from the Center for Rural Health, really did a huge effort on calling facilities, validating data, et cetera. So huge thanks to them. So the effort for this project was the kind of the maternal cycle of care, which includes pre-pregnancy care, maternal care, labor and delivery, postpartum care, and well woman care. And in this report, we're going to provide detailed information pertaining to access to care out in regards to outpatient, prenatal care, and inpatient maternal health services, and in regards to providers, nursing, access to behavioral health care, and support services. And I may not get to all of those elements because I have a 20-minute time frame, and I'm hitting some highlights in the report. So I just wanted to briefly present to you the data sources, a huge number of data sources. They're on page 18 of the report, and it gives the details under the titles of what exactly was accessed from all of the different organizations. So the first thing I want to kind of present and foot stomp is that we looked at the maternity care need using US Census data. And of course, if you use US Census data only, which is the map on the left, then you're going to see that the urban centers in Kansas have the highest numbers of reproductive age women and potentially the highest need. To evaluate in
Hey
terms,
Karen, sorry to interrupt. We are not able to see your slides.
oh, well, let me check that. That's interesting. Okay, I'm gonna end the show. It's it says I'm sharing. Huh. Okay, let me hit it again. Thank you. Thank you very much. So are you seeing him now?
Yes. Yep, we see. There
There.
we go.
Okay, there. Sorry, thank you. I thank you for interrupting and letting me know that. I thought I pushed the button.
That's all
So,
right.
let's just go back. There's the front cover, and I briefly introduced the individuals and the highlight of the focus of the report. And as I indicated, that on page 18 of the formal report, the data sources are listed and exactly what was provided from each of those data sources. So now we're on to these two maps that I was explaining. So the first map on the left is the one that just shows the census data and from 2022. And that's kind of all even we needed to be able to use the census data and also the KDHE data to get at the number of births by county, which is the right-hand side map, and then the ratio by the census data. So what is we really want to be able to point out is that when you look at the ratio of births by county and not just the overall population, you see that that this myth that the rural counties are dying and there's no births, and maybe people even maybe think, oh, there's no need for obstetrical care services because there's nobody having babies. This map on the right-hand side kind of debunks that idea, because we have two counties in particular, Grant and Wallace, that are very dark blue, and some light blue counties around them, which and then no dark blue counties in on the east side as much, and of course not in Sedgwick or Johnson County that were dark blue previously. Those two counties, Wallace and Grant, as you'll see going forward, don't have prenatal care, OB inpatient care facilities. So we wanted to highlight that. So this is a map that is in the report as well, that shows every inpatient facility in the state as licensed by in Kansas for either critical access hospitals, rural hospitals, tertiary care centers, and birthing centers. We didn't map mental health care institutions or long-term care facilities. So this gives you an idea of kind of the landscape. And this then, we mapped the facilities offering prenatal and post and inpatient care. And of course, the availability of prenatal services within a county does not guarantee inpatient obstetrical services, which is evident in the map on the right-hand corner. And there's a wide variety of outpatient avenues. They include health clinics, federally qualified health centers, and in rural communities, outpatient clinics are often co-located with the hospital. But 41% of the Kansas counties do not have prenatal care services, and a lack of access to prenatal care equates to later entry into prenatal care and fewer visits. The map in the upper left-hand corner is the facilities with prenatal care, and the majority of prenatal clinics are for low-risk pregnancies, not moderate to high risk. Note that the huge area without any available inpatient care is in the southwest, kind of on the western side of the state. 59% of Kansans do not have access to local inpatient maternity care services. And as noted on the earlier slide, there is a higher proportion of need for care in Western Kansas, and the report by the Center for Healthcare Quality and Payment Reform has shown that the highest closure rate was in 2023. It dipped in 2024, but it's kind of approaching the 2023 rates this year. I want to say that in obtaining these data points, there are 3 hospitals that have closed since 2023, and one to OB, not closed. One is in Cheyenne County. They've closed their obstetrical services, and that's on the map. Scott County briefly closed theirs. They're looking at reopening those services, but they were open in 2023, closed since then, and are looking at reopening. And then just recently, there was a closure in Coffee County at Burlington. And then I also want to apologize to Amberwell Hiawatha. Our licensed facilities included one license for Amberwell. We caught Atchison and Lansing, and we missed Hiawatha, which is providing prenatal and OB services and is up there in Brown County. So we apologize for that, and we'll be correcting that on the electronic version of the manual. And there's Wallace and Grant County again. So another thing that we mapped was the provision of behavioral health care. Federal qualified health clinics provide behavioral health care, and they're starred. Certified community health behavioral clinics are on the map. They were previously called community mental health clinics. And in the legislation established community mental health clinics in 2021, and in 2024, Kansas was added as a Medicaid demonstration program for the certified community behavioral health clinics. But behavioral health is a complex, multifactorial field featuring a combination of a lot of varied specialties. So we tried to capture that, and the map on the bottom right-hand corner includes licensed social workers, professional counselors, substance abuse counselors, marriage and family therapists, psychologists, and psychiatrists. And we use their licensure business address as the point on the map to get some granularity on where the availability of services exists. So another important element when we talk about levels of care, which I will be speaking about more, is distance to care. So 3.6% of zip codes in Kansas are farther than 30 miles away from the nearest facility offering prenatal services, and 35.8% of zip codes are farther than 15 miles. And this is pretty much in line with the CHQ PR data. The top picture is prenatal facilities, and you can see the growing dark blue area is representative of greater than 30 miles in the lower picture. And keep in mind that in most rural areas, the distance traveled is unpaved gravel roads, which really increases the time. And also, the distances traveled that we've indicated are based on a straight line from zip code to zip code, facility to facility, rather than the roads that are most likely, crooked, curving, and gravel. And so there are a lot of women in Kansas that must travel up to 60 miles to arrive at a hospital. And there again is where Grant and Wallace County would be. So this is next map, which again is in the report, reflects the distance to travel to care for high-risk pregnancy and delivery. And in states like Kansas that are very rural, we're very dependent on a regionalized plan of care, a regionalized care system with levels of care. And high-risk resources, the way we defined it for this report, because some facilities may say that they have a NICU, but there may not be a neonatologist there. And for really high-risk pregnancies, there may be a need for a perinatologist, or what's also referred to as maternal fetal medicine specialist. So the way that we define that level 3 and level 4, which are these locations, is that ability to provide surgical, all levels of treatment, which all levels of treatment would just be a level 4, which is only Kansas City, and with the help of the University of Kansas and Children's Mercy, providing level 4 care. Topeka and Wichita have level 3 care. 75% of zip codes in Kansas are farther than 30 miles from the nearest facility. And you can see on the slide, the maximum mileage is 283 miles. So in rural Kansas, family physicians provide the bulk of care for birth through the lifespan, and they provide maternity care and are trained to provide operative deliveries when necessary. So they are able to provide the full scope of care for pregnancies from low to moderate risk. And luckily in Kansas, we have approximately 4.1 family medicine physicians per 10,000 residents, which is versus 3.9 physicians per 10,000 residents in urban counties, which is a direct opposite of national data. But that's a good direction because we are a rural state, and that is an indication that hopefully we're pushing those family medicine physicians out to rural communities, and that's exciting. There is a recent report that says that by 2030, 2035, we are going to have a fairly major shortage of family physicians. So that's important to keep our eyes on that. The other thing is that while we're doing a pretty good job of getting family physicians out in the rural communities, their ability to provide maternity care is dependent on that facility's ability to provide those services. So that's another element. So when we look at the specialists that that assist in providing that next level of care, that would be OBGYNs and pediatricians. And this becomes a little bit more stark. So this reflects our ability to provide regionalized care and being able to get those mothers to the next level of care. And you'll see that 61.4% of counties do not have an OBGYN. And where we do have OBGYNs, it's limited. And that's actually why we made those numbers so small on the bottom, because we want to be able to show that span of numbers is that where they do exist, the numbers are very small. They're even a little bit more stark are the numbers for our pediatricians. There's only 330 licensed pediatricians in Kansas. And the right-hand picture shows that where their locations are. And I also wanted to add in the report that we aren't filling our residency slots for pediatrics. And we haven't for the last 2 years, and even beyond that. And they increased the slots, but they're not being filled. So this is an important element because of course, from our OBGYNs and our pediatricians, we get our next level of care, which is the maternal fetal medicine specialist and the neonatologist. So without the OBGYNs and pediatricians, we also don't get the next level of expertise. We looked at the certified licensed nurse midwives in the state, and there are only 81 nurse midwives in the state licensed through the Kansas State Board of Nursing. We do have certified professional midwives, and we have lay midwives practicing in Kansas, but those are slightly more difficult to track, and so we didn't map them. And a certified professional midwife is not necessarily a nurse, and they're therefore the licensure body within the state of Kansas is the Kansas Nursing Board of Nursing, so it makes it difficult to track them. What I will say is that they do have a full full scope authority in Kansas, the certified nurse midwives. But, and this is a great new change, but there's been a slow uptake of the hiring of nurse midwives in rural communities as the nurse midwife scope is more narrow than that of family medicine, who cover the emergency department and provide all the on-call services for rural hospitals. So, and then again, and if the nurse midwife's not able to assist with operative support, then that requires a physician to be on call or two physicians to be on call, increasing that need. So that's another element that we need to overcome, maybe with training and education. We mapped the anesthesia experts in the state. These highly trained providers are skilled in airway management, patient stabilization, initiating blood transfusion protocols, and managing patient status during surgical procedures. These experts may be physicians, anesthesiologists, or they may be certified nurse anesthetists, CRNAs. And many of the counties are covered solely by CRNAs, 43.8. Which where they're not available, that is a very costly contracted service. This map came from the Kansas, the Nursing Workforce Center, and it just gives you a quick picture of where we stand with nursing across the state. And obstetrical nursing is a specialized field that requires expertise and, of course, maternal fetal assessment and the care of the laboring and postpartum patient. And in most of our rural facilities, the RN is generally the highest licensed member of the healthcare team on site 24/7, 365 days a year. And they generally provide that initial assessment and determination of care at the point of entry. So David mentioned that the Medicaid issue. We wanted to provide a breakdown of payment on Medicaid for the state of Kansas, and so we took the births by Medicaid. That's this ratio, this map. So it's the percent of live births that are Medicaid births per the state based on 2022 data. In Kansas, 41% of the births are covered by Medicaid. And I just wanted to add that our reimbursement rate for Medicaid, both surgical and vaginal delivery, is 70% of cost. And the vaginal birth after cesarean delivery is significantly lower at 61%. So challenges very quickly. We've identified that maternity care requires a specially trained interdisciplinary team of providers and nurses that have to be available 365 days a year, 24 hours a day. And meeting that need is costly, and it is requiring contracts for anesthesia, nursing, respiratory therapy, radiology, and transport services. We showed that close to 30% of the zip codes in Kansas are more than 100 miles away from high-risk services. We identified that most Kansas counties have less than 5 family physicians, which becomes a dire number when you need at least 4, 2 on call at any given time, and hopefully there's 4 to rotate that calls requirement. So that's a big need. Then we need to ensure that we have the right maternal level of care available at the right time, which requires significant planning and expertise, given that 61.4% of Kansas counties do not have an OBGYN. Another challenge is, and David kind of mentioned this, that particularly in rural critical access hospitals, their reimbursement model is a Medicare reimbursement model, so they're heavily dependent on Medicare reimbursement, which of course doesn't necessarily align with obstetric care. So the rural hospitals that are offering obstetrical services are maintaining costly contracted services that may not be covered at all based on their cost and reports, which are always 1 year. That it's always the previous year, and they may be changing all the time because of that contracted need. We need to maximize our maternal health workforce, and then of course there's a need to maximize our teleradiology, particularly with that regionalized plan of care. But that requires that need to make sure that we get that mother to the right place at the right time, which is one of the elements I listed here, that we need to promote culturally relevant care. We need to promote transportation needs, and then to make sure that we do get those mothers to the right place at the right time. We need to look at accommodations for early and long-term care at regional and tertiary care facilities. And given that 86% of Kansas hospitals are experiencing a loss or did experience a loss of services in 2023, 63% are at risk of closing, 23% are at risk of immediate closure, as well as we are even seeing our birthing centers struggling to maintain their services due to low reimbursement. We need to look at that reimbursement model. And then, as I mentioned, we have to really utilize in-state I kind of foot stomp that in-state piece. Right now, a lot of our teleradiology is being done by out of state. And that then limits that referral capability because we don't have a one-on-one relationship with that teleradiology service aligned to the next level of care, i.e. be it Wichita, Kansas City, whatever, but we need to really work on making sure that our teleradiology services are in-state services. And we're ready for the panel.
Excellent. Thank you, Karen. I think you gave us a lot to capture on, and really this is the start of a discussion we hope to continue having at the Health Fund, and this data is going to be foundational for that. And I think taking a really hard look at the challenges as well as policy considerations is really valuable. So thank you so much, Karen. I'm going to transition to our reactor panel. We have great experts at the federal, state, local level, and from a provider perspective. So excited to start that discussion now. And our first reactor will be Ann Dwyer from the Georgetown Center for Children and Families. Ann?
Yeah, thank you so much, David. And Karen, thank you for this important report and your insightful and at times stark but important presentation. As David mentioned, I'm Ann Dwyer, and I'm an associate research professor at the Center for Children and Families at the Georgetown McCourt School of Public Policy. For those of you who may not be familiar with CCF, we are a nonpartisan policy and research center focused really around issues related to health insurance program and improving access, quality of care for children and families across the country. So for my remarks today, I thought I'd take a few minutes just to highlight the relevance of some of this important research and what Karen spoke about, given the changes to Medicaid that are currently being considered at the federal level. So I'll start off noting we have some great explainers and reports on our website that go into some of this in more detail and really highlight the important role Medicaid plays in supporting maternal and infant health, especially in rural areas. And I'll put links to those in the chat in a few moments. But as Karen highlighted today, Medicaid plays a critical role for maternal and infant health. It finances over 40% of births across the country, including in Kansas, and is a key player in combating the maternal health crisis. Medicaid is also a vital source of health coverage for women of childbearing age across the country. And as found in a report by CCF released last month, Medicaid is even more important to those living in small towns and rural communities. Studies have also linked Medicaid coverage for mothers and young children with improved health and lower rates of disability in adulthood. Medicaid coverage is also associated with higher educational attainment and greater financial security, and even improved birth outcomes across 2 generations, so really seeing that long-term impact. At the federal level, however, Congress is currently considering a reconciliation bill that would put immense pressure on state Medicaid programs, considering the largest budget cut to Medicaid in the program's history. According to the Independent Congressional Budget Office, 7.8 million individuals with Medicaid will lose their health coverage under the current bill language. The Kaiser Family Foundation has found that it would decrease federal Medicaid support in Kansas specifically by an estimated $3 billion over the next 10 years. And with these levels of cuts, states will likely have few choices, but to either raise taxes, cut benefits, coverage, or provider payments. There are also provisions in the bill that would specifically impact hospitals and rural communities, with even the American Hospital Association noting that if the proposed cuts are enacted, the effects would ripple across rural communities and could result in coverage losses, fewer available healthcare services, fewer jobs, and greater hospital financial instability. So these pressures or potential pressures on top of an already strained healthcare system, as the report today really highlights and what Karen covered in her slides, again, would put immense pressure on top of an already strained healthcare system in many places, in particular in rural Kansas. And then when it comes to coverage impacts, the Kaiser Family Foundation analysis also found an estimated 30,000 people in Kansas will lose their Medicaid coverage under the current bill language. This is on top of coverage losses due to ACA changes, but just Medicaid alone, their estimate is around 30,000 people. And given that Kansas has not expanded its Medicaid program and it doesn't have the Medicaid expansion, this means low-income children and families, pregnant individuals, seniors, and people with disabilities. So I know I've covered quite a bit in the few moments that I've spoken, and it is a lot to take in. I know it's a lot to take in for me as we continue to kind of unpack the language that we've seen out there. So I did want to kind of end on a bit of a high note and highlight some recent polling from the Kaiser Family Foundation on Medicaid from the spring. So overall, Medicaid is highly popular with the public. A majority of the public say that Medicaid is important to themselves and their family, and over 9 in 10 adults say Medicaid is important to their local communities. So of course, this is not surprising for many of us that work in Medicaid, but I did want to kind of highlight that it really is a popular program among the public. So with that, I will wrap up. Happy to answer any questions. I'll put some of those resources in the chat and we'll turn it over to Sapphire.
Thanks. My initial reaction to this report is now is the time in Kansas to support mid-level providers. We have such a grave issue here with lack of access and lack of care, lack of availability of care, especially in these rural areas. We can do better. We can't completely duplicate systems outside of the hospitals, but what we can do is we can support midwifery, community-based midwifery, as well as certified nurse midwives working within systems. We need to make sure that these mid-level providers who are able to care for the healthy, low-risk and moderate-risk patients, that they're available, that they have close proximity to these rural areas and the urban areas. We need to make sure that community-based midwives in particular, so your CPMs and also your community-based midwives who work within cultural contexts within small communities such as the Amish and such as the folks up in St. Mary's, Kansas, for example. We need to make sure that they have the ability to work within the state in a meaningful way, that they have the ability to care for their patients, that they're able to work and interface with our hospital systems that are still providing maternity care, to make sure that when a patient risks out of their scope of care, that they have a provider that they have a relationship with that folks can go to. Until we have those systems in place, we're not going to alleviate the burden on our systems of caring for these healthy, low-risk folks. And we're not going to be able to save that limited resource of those higher level providers for the folks that truly need them. Because as a reminder, not everybody needs a surgeon at their birth. We really also need to make sure that doulas are integrated in a meaningful way into our systems. When I look at the facts in this report and the fact that so many counties are not in close proximity to care, I think doulas are really the best positioned professionals to help alleviate some of that burden. Doulas, while they're not providing clinical services, are providing support to the families. They are making sure that the families are better informed and that they're more engaged in their care. They're helping make sure that families don't fall through the gaps. So now is also a really crucial time to make sure that we're training community-based doulas across the state, which Kansas Birth Justice Society actually has a goal to train 200 across the state of Kansas, particularly in Western Kansas this year. We need to make sure that systems recognize doulas as non-clinical care providers, that we're allowed in the room, and that we're seen as a member of the team. And I think globally, we need to remember that economics are policy, and policy is a matter of life and death. The fact that we have not expanded Medicaid has killed birthing people in our state, is going to continue to kill birthing people in our state and lead to these poor health outcomes. We need to acknowledge that this is a structural failure of our maternal and healthcare systems. Until we have Medicaid expansion, until we have reform around payment models, we're not going to get past this. I think what I want to emphasize most to all of you is that the solutions that we need here at this table are not hospital-centered or hospital-led. They're alternative solutions that are going to be community-based and community-led, working in conjunction with the existing systems. We need to make sure that we have wraparound support for all of these folks, most particularly in the rural areas, and that we're bridging those gaps by resourcing the folks who are on the ground in those communities, who are well positioned to provide that support through the form of community health work or doula work. I'm really encouraged that a year ago, it was actually July of 2024, Kansas Medicaid became a reimbursement state for doulas. We still have a lack of access to doulas because there aren't enough of us out here. And so that is, to me, target number one for making sure that folks out in these rural areas and areas with lack of access to providers are able to have a first point of contact. A doula also is going to be somebody who bridges the interface between folks and enrolling in Medicaid and accessing other types of resources that might be available to them. So I think what I'd really like to emphasize here is that policy and structural failures are how we've come to this situation that we're in. We can fix this, but we've got to do it together in collaboration and cooperation with all levels of care providers, not to the exclusion of doulas or midwives. And thank you for this important report. I think that this really gives us a lot to build off of, and it emphasizes the need for change in our state. We have so much work to do.
Thanks, Sapphire. And I think Dr. Aller is up next.
Hi, everybody. I am Dr. Beth Aller, and I practice in Rooks County, Kansas. I was a nurse first and then decided to go back to medical school because I saw the great needs in patients having a medical home and a primary care provider they could trust. I didn't have any expectation though or interest of doing rural medicine. It was because I did a rotation out in Rooks County when I was in medical school that I realized the amazing opportunities that practicing in a rural area gave and the wonderful relationships that you were able to have with your patients. So I went back my third and fourth year, and then in residency got asked if I would like to come out to Rooks County and join the medical staff there. So immediately after graduating from residency at Wesley in Wichita, I opened a practice with my spouse in Rooks County and have been serving the community for the last 14 years. When you practice in a rural underserved community, it means you cover the ER and do inpatient care, outpatient, nursing home, hospice care, all of the things. And for me, it also meant doing obstetric care. OB was a huge love of mine from the first baby I delivered, and I knew that it had to be part of my practice wherever I went. When I joined Rooks County as a provider, the plan was to have 4 of us who were physicians who were going to do deliveries, and then an additional physician who could do surgical backup for C-sections. Within the first 2 years, my spouse decided that he didn't want to do OB anymore. He had low numbers and had just kind of lost the desire to do that. So we were down to 3 of us. A few years later, we lost another partner who went to teach in Wichita in residency, again, another important thing. And then about a year and a half after that, another partner moved. So this left me and one other physician who we had been able to recruit, who did deliveries but was not trained to do operative deliveries. And so this meant for the last 3 years of me doing OB, 2 of them were spent never being off because I needed to either be available for C-sections for my partner unless I could arrange other backup. Then when that partner left and moved to Alaska, for the last year, I was doing OB alone. And so I had always been extremely proud that our county wasn't on the maps that we looked at earlier today, that we weren't on the maternity desert map. And I was heartbroken when I realized that our maternity unit was going to close. However, I couldn't do it anymore alone. I knew it wasn't feasible to keep going that way. I tried everything I could think of and we could think of to recruit another physician. But even in those years when it was two of us, it was extremely difficult. I have 4 children, and it was getting to the place where I was missing so many things, and it wasn't good for me either. So we are lucky now to have an OB-GYN who's coming from Salina and can help do prenatal care in our facility, but that still means traveling 2 hours away for our patients for delivery. And the closest place to deliver is Hayes, which from where I lived in Stockton is 45 miles away. It's hard to get providers to rural Kansas, and it's even harder when you realize that a large majority of family doctors who graduate residency don't plan or have an interest to provide obstetric care, or they're not fully trained upon graduation to provide this care, which would require them to complete a fellowship to be trained to practice OB, especially in rural areas where you need to be comfortable taking care of things often on your own. Without Medicaid expansion, our state's already experienced an enormous loss of medical funds, and we have seen poor maternal and child health outcomes. And with proposed cuts coming, it is going to be even more difficult to provide this care, but also to recruit care, recruit those to provide this care. It's also very difficult to reopen a maternity unit after it has been closed down. You lose those nurses and those other ancillary staff who have been trained to do obstetrics. So those of us who are in rural areas continue to take students and residents to help expose them to the opportunities of rural medicine. That's how I got there. But we have a long way to go. And speaking to the issues that Sapphire was discussing, I had a midwife in my practice for 4 years and absolutely loved having her with me. She also ended up moving. But it was wonderful to be able to add that. And while I absolutely agree that everyone doesn't need a surgeon at their birth, everyone needs access to a surgeon at their birth, because some of these scariest situations any of us who do obstetrics know are the ones where you have no expectation of anything going wrong, and then all of a sudden you need that help. So when you have expanded midwifery, you still do need to have either the family medicine doc or the obstetrician available to do that backup and have that really good collaborative relationship. But I would love to see the expansion of midwifery in our state. I also had a doula in our hospital that it was very important to me to start offering those services. So for the last 9 years of my practice, I convinced the hospital that we needed a doula, and I had a doula that was offered at no cost for all OB patients in my hospital. And that also brought such a wonderful added range to the services we could offer. I also made sure and told the hospital we needed to have a lactation consultant on site. And so 2 of my doulas were also lactation consultants, and we were able to have that have that offered, and just being able to offer things that you can't get everywhere else. Water birth, lots of things like birthing balls and moving as much as possible, not staying in one place, lights down, essential oil diffusers in the room, all of the things that just make birth not feel just clinical, but feel like the experience you want to have. And I miss it. I miss it a lot. And it was a huge part of the joy in what I do. I love still seeing the babies that I have delivered and getting those mamas with their babies back after someone else has delivered them. But it also breaks both of our hearts, and I always hear it just wasn't the same. So this is something I am dedicated to doing all I can, even if I'm no longer able to deliver right now, to do what we can to expand access and keep things going.
Thank you, Dr. Aller. And I think Cindy Samuelson rounds out our discussion.
Yeah, thank you so much, David, and thanks to all of our panelists. There has been great insight today. Thank you also to the University of Kansas School of Nursing, as well as the Center for Rural Health, and of course the United Methodist Health Ministry Fund for this great report on access to maternity care in Kansas. And I'll wrap up our panelists' remarks just with a few from the hospitals across the state. We think it's really important. This report highlights all these challenges. Also important to note that, and remember, it's not just a challenge in Kansas, it's a national issue, but it's so important for us here in the state, especially with the points folks are making about a rural state and the rural state of Kansas. So important that we're addressing this here. From a hospital perspective, I think it's really important to note these efforts that we're talking about today are exacerbated by under reimbursement as well as workforce shortages in our state, specifically tied to reimbursement from Medicaid as well as commercial payers in Kansas. There needs to be efforts to better cover the cost of labor and delivery services from Medicaid and commercial payers in the state of Kansas. Another thing specifically of the workforce area, there is a high cost for CRNA, Certified Registered Nurse Anesthesiologist, or you know what I mean, the folks that help us make sure we're in a place where we actually can deliver. And unfortunately, their services are not adequately covered by Medicaid. So it's important for a state like ours, Kansas, to have this really skilled workforce that can even be harder, as folks have mentioned today, in our rural areas in the state where we have under reimbursement as well as additional financial challenges due to rural locations in our state. I think we have in the chat, we can put a link to the HPSA map. That's a map many of us are familiar with that really highlights the Kansas health professional shortage areas. And it's important for us to continue to know that we do have a lot of shortage areas in our state, as this report highlights. It's also important to note that maternity care overall for all the hospitals in the state is a very expensive care, but it is even more expensive when we're talking about hospitals that may only deliver like 70 births a year or less. So that's a very expensive service for a rural hospital to provide. So some of the solutions we've talked about today do make a lot of sense. And in due of time, so we have plenty of questions, I'll just wrap up my comments by saying on a positive note, it's one that I think has been something hospitals across the state have worked on very closely with the Kansas Perinatal Quality Collaborative in our state. We're putting a link in the chat to that work. All of the birthing hospitals in Kansas are a part of this quality collaborative, in addition to 11 other hospitals that aren't birthing hospitals. They're really engaged in the efforts and are very committed to safe environments for all deliveries in our state. And I think that's a positive note that there is so much engagement in the quality care that moms and babies are receiving in Kansas. So I know we want to save time for questions, so I'll turn it back to David to take us into that area.
Excellent. Thank you so much, Cindy. And thanks to all of our panelists and presenters. I think it was really a robust discussion. Do folks have questions? Either please put them in the chat or use the raised hand function. I did see one raised hand as well. As folks, oh, I see something from Sherman Smith in the chat. Sapphire, you said the failure of Medicaid to expand, the failure of Kansas to expand Medicaid has killed birthing people in our state. How would you qualify that for skeptical policymakers?
I think it just froze. Are you able to hear me?
Yep.
Okay, I think my video is frozen, but I'm going to go ahead and keep talking as long as you can hear me. I would say that the parallels that I would draw between the failure to expand Medicaid and how that has actually killed birthing people in our state is that there are folks in our state, you can look at the data, who are not accessing care enough, who have existing health issues that could be better cared for if they get into care earlier. And I think lack of access to care broadly can be tied not only to lack of expansion of Medicaid, but the failure to reform the payment models. We don't have enough providers who are enrolled as Medicaid providers in the first place. So even if we did expand Medicaid, we would still have that problem on our hands. But I don't think that it's difficult to draw the parallels between lack of access to care and lack of access to insurance. If folks don't have insurance, they aren't going to get into care. There are hard barriers there. And until we fix that, the hard truth of it is we are going to continue to see huge disparities in birthing people dying in our state.
Sapphire, thanks so much for those comments. And Sherman, I posted in the chat a link to just one of the many studies that show the correlation between reduced rates of maternal mortality to states that have expanded Medicaid. And I think the same could be said for infant mortality as well. And I don't know if you have anything to add on some of the national studies on that.
Yeah, I can throw. We have a paper in the chat, and I would note that there currently in law is an incentive for states that have not expanded their Medicaid programs, an additional incentive on top of the 90 enhanced matching rate under Medicaid. However, under the current reconciliation bill, that incentive would sunset and no longer be available to states like Kansas should they decide to expand moving. So we have an explainer on our website of all of the provisions, those impacting expansion and other parts of the program, because there are, as I mentioned, many other the program also impacted by the provisions in the bill. I'll throw a link to that in the chat for those that are interested in learning.
Excellent. Thank you so much, Anne. We have a question from Dakota Starrin in the chat. Dakota's with the National Academy of State Health Policy, NASHP. Can any of the speakers share policy strategies that have been considered or implemented in Kansas that have addressed maternity care deserts and improved maternal health outcomes? I'd love to have folks weigh in. From the Health Fund perspective, we see this research as catalyzing a discussion on this very thing. How can we work on policies and programs to address some of these challenges, be it Medicaid reimbursement, improving Medicaid, expanding Medicaid, protecting Medicaid, strengthening the care team, which Kansas has made progress on in terms of reimbursement for CHWs, for doulas. We're having discussions about community paramedics, looking at transportation. So I think all of these are part of the discussions, but I'd love for the panel to weigh in. I think it's a great question, and we'd also love to learn from other states. The panelists have thoughts on policies that we're working to implement to address maternity care deserts.
Yeah, expanding Medicaid.
I'll add.
Again, it's like a broken record, right? But it's true. That's where it all starts. It starts with access to care. I delivered people who came in with no prenatal care, not because they didn't care about their baby, which I feel like is the narrative that gets thrown out there. That's not it at all. It's because they couldn't take off work to drive 2 hours, which means by the time you drive 2 hours, you have an appointment, you drive back 2 hours, that's an entire day. They can't miss a whole day off work, certainly not at the end of pregnancy when you get to needing to go every 2 weeks or every week, possibly. And so lack of healthcare coverage means lack of healthcare, and not because people don't care, but because they do not know how they're going to pay for it or how they're going to keep their job while doing it.
I might just add, it isn't maybe a policy that's in place or one that's directly being worked on, but that comment that I made on the bottom of the one slide about teleradiology, that's an important element that it does impact our ability to refer in state. I will add that we have an initiative underway right now across the state that we recognize the need. Dr. Aller brought up the fact that, especially people needing to drive 2 hours, maybe multiple times in a week to get sonograms or assessments, antepartum assessments. We're training generalized sonographers that don't have OB image experience necessarily, or if they do, it's basic level OB imaging experience that limits the images that are then sent to be evaluated by maternal fetal medicine specialist. We have a program underway that we are using a simulation capability trainers to train OB sonographers so that those images in rural communities are really good images that can then be sent to individuals to review them. And then that saves patients from traveling long distances. But we're still going to have to work on getting that mother to the right place at the right time if she does, in fact, need a higher level of care.
Anyone else on this? I think this is a great discussion, and I think this is where we hope to go. What policies, what programs, what coordination and training we can do to help eliminate deserts, but really address gaps in care.
Yeah, and David, I was just gonna highlight that the work we're doing to increase reimbursement for these services from commercial payers as well as Medicaid is an ongoing effort that we're working heavily on.
Excellent. Thank you, Cindy. Other questions that folks have? And I think Amy noted in the chat, the report references the building out a hub and spoke model that should be considered and strengthened wherever we can. And I think that's really a good point. I think we've seen some great success in other states with hub and spoke models. And I know that this is a lot of work that's being discussed. I guess I have one question for Dr. Aller because I thought she had some made a really important point, and I think it would be great for others to chime in too. One of the things Dr. Aller had highlighted was just that there may not have been the support for her as an individual provider that really wanted to continue to provide OB services, but was like alone. So are there things that we can do to better support the existing OB providers so that you're not burnt out? And how can we look at that from a systems lens?
I wish I knew how to get more providers to rural areas. But much like me and someone who came out having no intention of practicing rural, not because I had anything negative against it, I just didn't know it. We have got to get, and I think it's even earlier than medical school in a lot of cases, right? I think we've got to start in high school, we've got to start in college, letting kids see the options of rural healthcare, get them excited, get them know that that's what they want to do. Because often by the time you get someone in medical school, it's already too late, right? They've either already, I'll have people come out fourth year and be like, it's so cool out here, but they've already declared and matched at a residency at that point. So it's getting people interested in primary care and have that as what they want to do. And then also realize all of the benefits of practicing in a rural area. But reimbursement is not one of them, right? My kids will laugh at me and be like, doctors are rich. And I'm like, not if you do rural healthcare. It's not why any of us do it. You don't do this work for that. However, fair compensation is important. And when it's things like, yeah, we had a CRNA that was my full anesthesia provider. When you don't get reimbursed adequately for that, when your CNMs don't get reimbursed adequately, I basically told my hospital they were going to give me a doula and we were going to take care of it, but we didn't get reimbursed for that. All of those things would help allow a hospital to stay going. The more the hospital can be financially solvent, the more you can be able to actually recruit more physicians there, and just having adequate payment, because it's a lot to ask somebody to do rural in general, even when we had 4 providers on. But without having enough people to make that call pool, you are going to burn out and people are going to leave.
Thank you, Dr. Aller. Did anyone have anything else to add? I know we're bumping up against the hour. Great. Well, thank you again to all the presenters and to everyone for attending. As I mentioned, we view this as the start of the discussion in terms of how we can improve maternal health care in Kansas and how we can work together. I think it's critical that we're all together at the table, hospitals, other providers, family physicians, OBs, doulas, nurse midwives, nurses, really just our focus is just multifold, and we'd love to have continuing engagement. We're planning community convenings throughout the fall to help inform our program and policy strategy. But we know it's critical in the short term that we protect Medicaid and protect federal funding. One of the things that Kansas did, which they deserve a lot of credit for, is successfully secured a transforming maternal health grant from the federal government, which we secured successfully at the beginning of this year. Some of that funding could be in doubt due to federal cuts. And really, where some states have shored up payments for maternity care, New Mexico has leveraged state-directed payments to increase rates for maternity care. Those things are threatened by the latest cuts at the federal level. So it's really critical that we protect Medicaid, we continue to work to expand Medicaid, and we come up with ways to strengthen Medicaid and other reimbursement forms like commercial payments to improve maternal health outcomes. Thank you all for joining us, and we'll look forward to the next conversation. We will send out links, slides, and a recording of this presentation. And I do want to thank the Health Fund team, Nancy, Katie, Jeff, Jackie, and Jennifer for all their work that they put into this. So thank you all and have a great day.